Hello everybody, I'm Bill Shields and I'm here today to talk to you about how I use lung ultrasound in the emergency department. I'm also going to be going over some of the findings and approach that people are reporting throughout the world in regards to suspected or confirmed COVID-19 patients during the current pandemic. This is not meant to be an all-encompassing lecture or talk on lung ultrasound, but rather a brief overview of how I use it in some of the more basic applications. I want to give a special thanks to our third year resident, Dr. Cody Bonk, who helped put this together. We'll first be going over the basic approach to lung ultrasound. We'll then go over some basic lung ultrasound anatomy and pathology seen on ultrasound. And finally, we'll go over a focused discussion on what we're finding in patients with confirmed COVID-19 on ultrasound. So first, who do you scan? There are lots of indications to scan the lungs on a patient with ultrasound. One of the most obvious is trauma, to look for things like pulmonary contusion or signs of a pneumothorax, which we'll touch on briefly. And then we'll be looking at patients with medical complaints with dyspnea, hypoxia, tachycardia, or hypotension, basically abnormal vital signs in an undifferentiated patient. Finally, if you're going to be reaching for your phased array probe to perform a bedside echo, I would strongly suggest that with that you perform a lung ultrasound as well as looking at the IVC to help give you a better understanding of the patient's physiology and their current presenting symptoms. There are other special considerations to think about, especially in the populations of cancer patients, given that they might have unique findings and be more prone to things such as pleural effusions, and also as an alternative to CT imaging or X-rays in patients that are pregnant to limit radiation. So how do you scan? First, you want to choose your probe, and I would suggest that you can use whatever probe you feel comfortable with. I typically scan with the phased array probe, mostly because I'm already using the probe to look at a patient's heart, but I commonly find myself also using the curvilinear. There are people who prefer one over the other. To me, I think they're both very adequate as long as you're using the lung ultrasound settings, which is really key based on what we know about lung ultrasound. I would switch to my linear probe commonly if I want to get a better assessment of the pleura, or I can't tell if someone has lung sliding or not. It's a good alternative to the curvilinear and phased array for the more superficial structures, but tends to be what I go to if I'm just trying to really look at the pleura. So now that you've selected your probe, you want to make sure that you're scanning with the probe marker always facing towards the patient's head. And then you should choose a systematic approach that works for you, that you'll remember, to ensure that you're scanning throughout the chest. And that includes all the way up to the apex and through the bases. Sometimes you'll only be able to scan the patient's anterior chest or their posterior chest based on patient positioning or their comfort. However, if you're able to, consider dividing up the chest into 4 quadrants as shown here, and into quadrants as one can do on the back. And you really just want to make sure that you get a good assessment of the vast majority of the rib spaces. Here's an example of how you may scan someone on their anterior chest, making sure you get all the way up to the apex, all the way over to the sternal border, and then making sure you get all the way to the lower lung field. You'll then want to ensure you look near the bases while the patient is supine in order to look for pleural effusions. Next, if the patient is able to, you want to sit them up and look at their back, ensuring to look all the way up to the apex and getting down to the lower lung bases, all the way down to the level of the diaphragm. If you find an area of interest, I suggest turning your probe in the horizontal plane to look through that rib space. Next, let's go over some basic lung ultrasound anatomy and pathology. Hopefully this is a review for much of you out there. If not, there are plenty of sources online and in textbooks that will go over some of these in a more detailed fashion. So first, let's go over the pleura. So here is a still image with a linear probe. Given that our probe indicator is always going to be facing the patient's head, their head would be off to the left here, and their feet would be off to the right. And this is exactly what you want to see of all patients. You'll see the skin and muscle on the chest wall here, followed by a rib with a rib shadow, another rib and a rib shadow, and just below the ribs you'll find the pleural line, which is right here. Down below you'll find repeating A lines, which is a horizontal line here, which I'll go over in a few seconds. Here's a cartoon of what I just described if you need to see it highlighted. Again, you see ribs with the rib shadow, the pleura, and the lung underneath. Here is a movie of the same clip, and here's where we'll talk about lung sliding. As you see, the movement here is kind of a shimmering, or people call it ants marching, some people call it a sliding. To me, you clearly see a gliding here of the two pleura. You only get this if the pleura are in contact, both the parietal and visceral pleura. Here is a phased array probe of the same thing. You see the chest wall up here, a rib shadow, and a rib over here, and you'll see the pleura sliding. You kind of get that shimmering or that artifact up there showing that the pleura are in contact with each other. What this looks like on a CT, if you could zoom in, which you would be seeing the parietal and visceral pleura right up against each other, and when someone's breathing, these move against each other, which is what gives you that shimmering artifact. Here's another picture with a linear probe. Again, you see a rib here with a rib shadow. You see another rib here with a rib shadow, and just below that you see the pleura. And notice you don't see any of that shimmering or any of that sliding. This tells you that this person likely has a pneumothorax there in the correct clinical setting. There are some caveats to this, but the vast majority of the time this will likely be what indicates a pneumothorax. To help kind of hammer that home, what happened in pneumothorax is what you see here on a CT scan. You see the parietal and visceral pleura are no longer in contact, and so if someone was breathing, you don't get that sliding effect seen in ultrasound, since the pleural lining is no longer in contact. Here they are side by side, a patient with sliding. Again, you see that shimmering or that sliding artifact, as opposed to the picture on the right, where you see no sliding, indicating a pneumothorax. Once you find a patient that has a potential pneumothorax or no sliding, I suggest you keep looking a little bit further to confirm this. And what you want to look for is what you see here, which is a lung point. Again, to show the anatomy of a rib with a rib shadow, a rib with a rib shadow on the right here. And then at the pleural line, you see some sliding off on the right, but not on the left. And that's where the lung is coming in and out of contact with the parietal pleura. To look at it a different way, you can see this cartoon of a CT scan here with the probe in contact with where the lung is in contact with the chest wall and where it kind of dives away, which is what you would see here on this picture on the left, where you see sliding on the left side of the image and then no sliding on the right side of the image, indicating a lung point, and that would be where the lung dives away from the parietal pleura. This is diagnostic of a pneumothorax. Now that we've gone over the pleura, let's go over what A lines and B lines are. To many people this is very simple, but it might seem very complicated to a lot of people. But really all you have to be able to do is identify horizontal lines versus vertical lines on the ultrasound machine. So we typically see patients with either predominantly mostly A lines, and we say they have an A line profile, and that is what you typically see in a normal, dry, healthy lung, versus a patient with predominantly B lines, and you would say that they primarily have a B line profile, and that's what you typically see in various lung pathology, which we'll now go over. So an A line is basically a bright or hyperechoic horizontal line that's a repetitive reverberation artifact of the pleura. This is at equidistance from the pleura to the probe and repeats over and over. Basically what that means is you have repeating bright horizontal lines below the pleura. You see this typically in a normal dry lung. You also see this in patients with asthma or COPD, since they're typically not fluid filled or filled with fibrosis. This is also what we see in a pneumothorax, given the pleura is very reflective, and most commonly you'll find this in a pulmonary embolism unless someone has a lung infarct. So what does this look like on a cartoon? We've already seen this, and now we just added in what an A line is. An A line is just a repetitive bright line that is below the pleura. You notice that this is about equal distance from the pleura to the chest wall as it is from the pleura to the first A line. Here it is without the cartoon overlaying it. You see the pleura here, and then you see the A line down here. This is what you'd be expecting to see in a normal dry lung. We've already seen this slide, but here I want to point out A lines. Again, you have a rib with a pleural line, and then followed by repetitive A lines, which you see here, and again here. Again, typically what you see in a normal dry lung or someone with asthma or COPD. Here it is kind of showing that they're equidistant apart. Here's just another good example of A-lines with a curvilinear probe. You can see the two rib shadows here, followed by the pleura just underneath it, and then you see repetitive A-lines deeper into the lung tissue, again indicating someone with normal dry lungs typically, or asthma or COPD. So now that we've gone over what horizontal lines are, or A-lines are, we'll now go over B-lines, which are described as laser-like hyperechoic lines arising from the pleural line. They move synchronously with lung sliding or breathing, and they go all the way to the bottom of the ultrasound screen without fading. Basically what this means is the bright line coming from the pleura, which moves all the way down to the bottom of the screen with breathing. And based on various patterns that you've probably already would recognize from chest x-rays, you'll see people with heart failure with diffuse B-lines throughout their chest given pulmonary edema, or someone with interstitial lung disease. Someone with ARDS, you might see more of a patchy areas of B-lines, as one would expect as they see a patient with ARDS on their chest x-ray or CT scan. And then if you have someone with more focal B-lines in an area of, let's say, in a trauma patient, you could very likely assume a pulmonary contusion in the right clinical context, versus a patient who's coming in with infectious-like symptoms and you're seeing focal B-lines, you might be more likely to see find something like pneumonia. So what does this look like on ultrasound? Here you see an image of it right here with a phased array probe. You can kind of make out the rib here and the rib shadows on both sides. Here you're noticing the pleura, and from this you're seeing these bright lines coming from the pleura going all the way down to the screen, which move with breathing, and this is a B line. I want to take a second to point out that you don't really see A lines here, which are the horizontal lines. When you have B lines, they usually wipe out the A lines. So this is indicating that this patient probably has a B-line profile and has some lung pathology, which you could probably sort out based on their current presenting symptoms. Here's another example with a curvilinear probe. You again see skin soft tissue followed by ribs, pleural line, and another rib here with a rib shadow. And you see all these bright lines that are coming from the pleura extending all the way down to the bottom of the screen, indicating B-lines. I want to point this picture out as it can fool some people, especially some more novice ultrasonographers. We see the pleura here, and you don't really see any of these horizontal A lines, but you have really confluent and such dense B lines that they all kind of run into one. But this is what you'll see if someone has severe pulmonary edema or fluid on their lungs. This is actually an example from a patient with flash pulmonary edema. Just something else I want to point out here. We have a picture on the left showing B lines. Again, you see the pleura and you see these bright lines coming all the way down to the bottom, indicating B lines and lung pathology, which is slightly different than what you see here on this picture. You see the pleura just below the rib shadows, and again you see some vertical lines coming down. These do not extend all the way down to the screen. This is our normal artifacts. These are called Z lines, as they are very short. Don't make it all the way down to the bottom of the picture. You can be rest assured that this is just normal artifacts that you see with lung ultrasound. Again, these are called B lines, which are pathology, and Z lines, which are just normal artifacts given the limitations of the ultrasound machine. So now that we've gone over the pleura, A lines, and B lines, we'll go very briefly over what an effusion or a consolidation might look like. So here's an example of a subpleural consolidation. This is a pretty clear and obvious case of someone with likely a pneumonia, especially in the clinical setting. What you can see here is that you don't really have a lot of pleural contact up here. You have this jagged or kind of shredded edge here with all these reverberation artifacts which look like B lines, and you even see some fluid moving within the lungs, which are called air bronchograms. I don't think you need to focus on that right now, but if you see something like this in the right clinical context, that's pretty indicative of someone with pneumonia or some other lung process. You might see something like this in a pulmonary infarct from something such as a pulmonary embolism, but you have to use your patient presentation to help you with this diagnosis when you're just starting out with lung ultrasound. Here's another case. I chose one that's a little less obvious because this is more likely what people are going to see in real life on a day-to-day basis. What you see here is you see a rib shadow, another rib shadow, and then if I pause the video right here, you'll see that you have this space here between what the chest wall and some lung down here. This is a subpleural consolidation, fairly large, again, possibly concerning for pneumonia or a lung infarct based on the right clinical setting. Here's looking at a patient in their right upper quadrant area looking for an effusion. If we pause the video here, we would see their liver and their kidney, a little bit of a grainy image, but under here you can see this is their spine. You can kind of imagine their vertebral bodies down here, and then here would be their diaphragm. Notice that you're not really seeing anything up here. You're not seeing the spine extending out, which would happen in a pleural effusion. So this is someone with probably a dry lung with no pleural effusion, as opposed to this picture here, where you see a patient's liver, you see their diaphragm, and then you see a pleural effusion just above the diaphragm. You can see the spine extending out right here beyond the pleura. You can only do this if there's some lung consolidation or fluid there. People call this the spine sign. That would kind of help key you in that this is indeed a pleural effusion. Finally, here's a much larger pleural effusion that you can see here. You see again the liver, you see somebody's kidney, kind of sort of doing a right upper quadrant view on an ultrasound for a fast, and then sliding up. And again, you see the spine extending up underneath the lung, indicating that this is indeed a pleural effusion, and you can see lung floating here. Lastly, I'd like to go over now a focused discussion on what you might see in patients with COVID-19 or what to look for if you're suspecting COVID-19. First, we'd like to review our current ultrasound workflow. We adopted this from Denver Health and appreciate them for sharing this. But basically our goal is to have you bring the portable ultrasound machine outside the patient's room, bring as minimal amount of materials into the room, the only probes that you want to use. Try to have gel already on the ultrasound probes. Bring in your gray wipes with you already so you can wipe down the machine before you leave the room. Wear your PPE as expected during the current COVID-19 pandemic. Bring your ultrasound in with you, and before you leave the room you should wipe down any obvious soiled parts of the machine, and then clean with your gray top while keeping the machine as far away as you can from the patient. Then you should again doff your PPE and remove the machine from the room with either your foot or gloves, and then again wipe down the machine outside the room, being sure to wait for at least 2 minutes until after the machine has been dry before using it again or storing it for later use. One example to keep the machine clean as possible and from becoming a potential fomite would be to cover the machine here as shown at the local VA hospital, covering in a clear plastic sheet and using a probe cover when available, hopefully kind of limiting any chance of contamination of our ultrasound machines. If this is unavailable, we strongly suggest wiping down all surfaces with a gray wipe, gray top wipe, as you see here in the picture. So there is a lot of ultrasound information coming out in regards to patients with COVID-19. We're seeing data from China, from Italy, and now from the United States. There are a lot of great resources out there, and a lot of ultrasonographers really coming together to share their information. I strongly suggest that you look for other sources other than just this talk to kind of supplement what we're talking about in this video. My favorite examples currently are the POCUS Atlas and also MedStudent POCUS with the site that you see up there, as they are continually updating and adding on material that people have been publishing throughout the world. So what are you going to find in patients with COVID-19, or what should you be looking for with ultrasound in patients suspected of COVID-19? First of all, they're going to have an irregular or thickened pleural line compared to patients with something like CHF. Their pleura is going to look pretty thick and maybe a little ragged or jagged. You might see some small subpleural consolidations. And then you'll see B-lines, and these can be in various patterns depending on the extent of the disease. These can either be focal, multifocal, or confluent. And then you might see things like translobar consolidations, plus or minus some air bronchograms. I think for a novice, these are a little bit harder to always appreciate, and so we'll skip that for now in our next few pictures. But if possible, with these patients, you'll want to try to image their posterior and lower lung fields if you're not finding any pathology anteriorly, as these are the locations that we're typically finding pathology, and especially early in disease. One thing to point out here is that pleural effusions are actually quite rare in these patients we're seeing. They're not having large pleural effusions like you might see in someone with a pneumonic or effusion from pneumonia, or someone with an effusion from heart failure or ascites. These patients are usually coming in with out pleural effusion seen at the bases. So here's an example of a patient from our department. You can see the chest x-ray is fairly unremarkable. However, this patient had an ultrasound performed before the CT, but I want to show you the CT here. This is just one slice. You see a small area of opacity here, which is kind of typical of what we're seeing for these COVID-19 patients as described in current literature coming out. And typically these ground glass opacities are coming out all the way out to the pleura, which makes it very amenable to ultrasound, since ultrasound is imaging the pleura and the surface just below. So here's that very same patient. Here's their ultrasound. This patient had already actually tested negative for COVID-19, but came back in with worsening symptoms, and given comorbidities, ultrasound was performed prior to CT scan, showing B lines diffusely. This is an anterior image on the left and a posterior image on the right. You're clearly seeing B lines on this patient who later tested positive for COVID-19 and requiring admission. You don't have to take just my word for it. Here's some data out of China, again showing these ground glass opacities and changes on CT scan, which are just below the pleura. These are better described in the radiology literature, but really want to point out that a lot of these findings are near the pleura, which makes them very amenable to ultrasound findings. Here's another example of a lung ultrasound from our colleagues around the world, shown on the POCUSatlas.com. Here what you see is a small subpleural effusion, which is dark or hypoechoic here, which is just above a kind of bright and thickened and kind of shredded irregular pleural line, which is kind of typical of what we're seeing in patients with COVID-19. Again, this isn't specific for a patient with COVID-19. It can be seen in other lung pathology or other viral pneumonias, but given the clinical context, this could be a potential diagnostic tool. Here's this example of the same image on the left, but a more normal appearing lung on the right, showing how the pleura is nice and thin. It's not real jagged, not real irregular. And you can compare that to the picture on the left, which is more typical of a patient that you would see with COVID-19, with, again, a more shredded and irregular and thickened pleural line. Here's another example taken from our colleagues across the globe from a patient with COVID-19. Doesn't project all that well on the screen, but we see the pleura here and here with a rib shadow. And what I want to point out here is when you stop it, you can see B lines coming from below the pleura. So the pleura should be up here. You'll notice that this is coming actually from an area below the pleural line, showing that there would be a small subpleural consolidation here, which in the right clinical context could be seen in a patient with COVID-19, as was this ultrasound. Again, here's another example with a patient with known COVID-19. You see convalescent B lines coming all the way down to the screen here. You see kind of a thickened and irregular pleura. There is a little bit of a space between the parietal and visceral pleura here, showing a small effusion, and this is indicative again of a patient with COVID-19. These images come across a little bit more clear, but are again findings that you'll be seeing in patients with COVID-19. Potentially, what you see is an irregular kind of thickened pleura, small subpleural consolidation as seen here on the patient on the left, with B lines coming all the way down to the bottom of the screen. Finally, here's another patient from our department here in Milwaukee, showing a subpleural consolidation. Not the most clear picture, given somewhat of the adipose tissue here that you're seeing, but if I stop the image here, you'll notice that this would be where the pleura should come in contact with each other. You notice this is a small subpleural consolidation right here with the B line emanating down. And again, this is what we can see in a COVID-19 positive patient on lung ultrasound. I also just wanted to briefly point out some additional ultrasound applications for patients with potential COVID-19. So I would strongly suggest using ultrasound for all central venous line placement and confirmation. It's also something that you could be using to look for pneumothorax with after placement of a central line, and potentially even pneumothorax from barotrauma in the setting of a patient being on a vent. I'd also strongly recommend looking at volume status, as we know these people can be a little tenuous with fluid, and also looking at patients' cardiac function, as there are some reports showing these people can have cardiomyopathies from a viral myocarditis. Other examples could be endotracheal tube confirmation. However, I still would probably suggest an X-ray to confirm tube placement if you're not comfortable with this. And then don't forget your other exams, such as the rush exam, to look for things such as hypotension and to look for alternatives of why patients may have abnormal vital signs or the symptoms they have. As always, not all patients are COVID positive, but you still want to protect yourself as if they are, but potentially use ultrasound as a tool to help guide you for other alternative pathologies. I just wanted to make one last point at the end of this video. I think even as a big proponent of lung ultrasound, I want to make sure everyone knows that lung ultrasound isn't something I advocate for every patient with COVID-19. Obviously, this is something we're actively learning about, but ultrasound does put you in more contact with a patient, potentially more risk with a patient with COVID-19. So always be sure to be protecting yourself appropriately, and just really consider the need for ultrasound, how to help triage patients, how to evaluate them in ways outside of typical radiation. If you're comfortable with it and understand the findings you might find in these patients, it can be a valuable tool. But again, be cautious out there and use it appropriately in the appropriate clinical situations.